and were recommended at that time to undertake an exercise test. An exercise test is a false positive rate in that it will indicate disease when it isn't present in about 10% of patients, and that's been generous to it. So of the 20 million Americans who start exercising, 2 million will have been given a possible diagnosis of coronary heart disease. At that time in America, you would undoubtedly have proceeded to coronary angiography. There would be very little alternative. Coronary angiography has a major adverse cardiovascular event rate of about 1 in 1,000, so by which time 2,000 of these patients would have died or have had a stroke. 10% of them would probably have found to have had a coronary disease, and in America at that time would have recommended to have had bypass surgery, which has a 5% major adverse cardiovascular event, resulting in 10,000 deaths or strokes. So by screening this population with nothing wrong with them to begin with, you would end up with 12,000 deaths or strokes at a cost of £20 billion. So perhaps maybe not such a good idea. So to screen, to test a symptomless population, this is the population. You screen in order to detect cases of a disease at an early stage. And the basic principle is it should be common and disabling, you should know its natural history, and you should be able to, there should be a recognisable pre-symptomatic phase. The screening tests that you use should be reliable, valid, repeatable, acceptable, easy to perform, and sensitive and specific, and most importantly, of low cost. And you should have a treatment and know what you're going to do with the results of your screening programme. So, we're talking really here today about screening in youngsters, and I'm going to confine myself to perhaps say the age of 12 to 35. And what we're talking about essentially are inherited cardiovascular disorders. And these are the sort of common ones. This list goes on and on. But hypertrophic cardiomyopathy, a thickening of the heart muscle, occurs in about, if you do population screening, about 1 in 500 of the population will have unexplained thickening of the heart muscle on cardiac ultrasound. And depending on which institution you believe, the mortality rate per annum is about 1 to 4%. I think in the general population, for those of us who are not in quaternary centres where you see the sickest of the sick, the true death rate is probably around 1%. So 1% of 1 in 500. And the other conditions actually go down, arrhythmogenic right ventricular dysplasia, dilated cardiomyopathy, the ion channelopathies that we talked on earlier on are even rarer. So this clearly a devastating problem. Please don't think that I'm trying to minimise or whatever this issue, but in terms of the numbers, it is potentially, as we start my talk, not a great deal of numbers. Now, these are all, I'm assuming you can all read, so I'm not going to go through all of this. So we need to, what population do we need to screen? Well, I've talked the underlying causes of sudden death in Scotland, the prognosis, the tests, etc., etc. So I'll go through this just now. A lot of this kicked off in Scotland after the death of Phil O'Donnell, well-known Celtic footballer and after the Motherwell footballer who died suddenly on the pitch. And Nicola Sturgeon, to her credit, acted quickly to set up the national screening programme in Hampden, where young athletes can be referred and be screened at no cost. What drove this, or the biggest driver to this, is from an Italian study. Sorry, this is me playing with a Mac, because I'm looking at the wrong side of the screen. Very good. So, can I go back through this again? This is Phil O'Donnell. I've been through that. This kicked off really again with the Italians. And the paper was published in Journal of the Medical Association in 2006, and it looked at the effect of a screening programme instituted amongst young athletes or people who are exercising regularly, and purported to show a significant and striking fall in death from sudden cardiovascular disease in those aged 12 to 35. And from this, guidelines have flown, particularly the European Society of Cardiology guidelines recommending that this be carried out in young people. And over the period of the screening period, the death rate in these patients, in these youngsters, fell to that of the general population. Now, can I point out, this is screening every 1 to 2 years. This is not one-off. This is screening them every 1 to 2 years. sorry, this is, I beg your pardon, this is right, okay. The problem with this is that it hasn't been replicated. This is a study from Israel, looking at 10 years before and 10 years after the introduction of mandatory screening for athletes for the risk of sudden death. Now, if I can take you through this slide, which is slightly complicated. The purple here is the region of Veneto. Now, what is also interesting is that all of Italy underwent this screening programme, but only Veneto reported its results. So you have here the instance before introduction of the Italian sports law, the fall in the death rate, down towards, and then down towards that below of the general age-matched population. This is the Israeli data. Now, if you just took the Israeli data 2 years before the passage of the Italian sports law, Israeli sports law, you would have seen exactly the same effect. And would have said, yes, mandatory screening, including an ECG, reduces death in young athletes. But if you look before it and go back, in actual fact, this was a blip, and it made absolutely no difference to the trend in deaths from in athletes. So the Italian study really is the only study that has been shown possibly to be associated with a reduction in death following a mandatory screening programme in people who put themselves at a slightly increased risk of death by the virtue of exercising itself. And it's calculated that using this data, you would have to screen almost 40,000 athletes to prevent or to prolong one life, and in the process would disqualify 790 athletes. Perhaps a better way to do it would just be to try and raise awareness amongst coaches and athletes of probable cardiac symptoms that might suggest that they're at risk and should be followed up. Now, the harmed experience itself, and I'm grateful to Professor Hillis for giving me this data, shows that approximately they've screened now 1,600 young athletes. And so far, what they've mainly found is 11 to 15% of high blood pressure. These are youngsters, these are not people, these are not over 35, these are youngsters have high blood pressure. On their ECG, almost a third have minor changes of uncertain significance, and they've all had echocardiograms, that's heart ultrasounds, and none have been shown to have any obvious abnormality or structural abnormality of their heart. Looking at the ECG itself and the time that the heart takes to recharge itself, this is the channelopathy that's associated with sudden death, about 5% of them have a prolongation of this recharging of the heart. But again, none of them come from with a history of any family history of major sudden cardiac death. Now, that's not to say that you can't screen. And in Ireland, they did pass a law mandating screening of youngsters who wish to exercise. And this is looking at the results from the West of Ireland screening for sudden cardiac death in young people. Now, a Group 2 ECG abnormality is that proposed by the Italians as being something that is not explainable by being a trained athlete. So this is Group 2 ECG abnormalities. And what they found was that the study showed that well, if we go to the second box and the green box, 30% of their youngsters had abnormal ECG changes, suggesting possible cardiac pathology. These are fit youngsters, probably the fittest of the youngsters. And if you looked at their questionnaire, which they're all given out beforehand, which is mandated as well about their health, 40% of them would have answered yes to a concerning cardiac problem, which would then have led them on to further investigations. And remember, this is a fit, young, healthy population. So, are there benefits from screening? Is being disqualified from sports and being informed that you perhaps have a potential lethal condition likely to affect your quality of life? I think so. What's the effect on your job employment? What's the effect on your cardiovascular lifestyle if you give up doing any kind of exercise? What's the legal position of barring you from a sport? Can you do that? And what are the demands of the service? It's already struggling in most countries to cope with a further 10% of screening. If we turn now to the general population, Norway and Denmark have populations perhaps about the same size as Scotland. This is Denmark. And in Denmark, up to the age of 35, there are 2.4 across a million youngsters. Sorry, I beg your pardon, can I start again? If you look at Denmark, in its general population, there are about 2.4 million people up to the age of 35. The sudden cardiac death rate, or contribution to deaths in that age group, is about 7%. And that works out for Denmark of about 67 per annum, or approximately one person up to the age of 35 dying per week, after excluding those who are already known to the services. We're talking here to try to prevent one person per week dying. You've seen this slide before, and I'll just show it again because I want to make a slightly different point in a minute. This is the incidence of unexplained at post-mortem. There is nothing found at post-mortem, therefore it's presumed to be a cardiac death. And in Denmark, it's about half of those who are dying suddenly. If we move to Scotland, and this data is from given to Professor Hillis' team, the bottom line here, in those up to age 35, shows an incidence of about 1.5 per 100,000 of youngsters will die per annum. Now that is significantly less than the number who die from drugs of death in Scotland. Significantly less than die, say, from heroin or drugs or alcohol. One group that we know are predisposed are those who are methadone addicts. Now the light grey bars here are those who take methadone, and the dark grey bars are a control group. This is the recharge, the time the electrical signal takes to recharge in your ECG. This is where abnormal would be to the side of it, and you can see the number of methadone addicts who have abnormal recharging of their heart cells. But when they die, and there's nothing structurally found, their death is put down to toxic effects from methadone, presumably from respiratory depression. But I would argue to you that percentage of these may die from electrical deaths. If we come back to the Scottish data in red, if we add these up, this is data from post-mortem, again from Stuart Hillis. This is from this is all deaths over a 22-year period. And in red, there are 1,207, which is about 54 per annum, or about 1 per week, which is working out as what other studies have shown. And it's probably about 1 per week is due to non-congenital or some acute heart disease. These are the ones that we try and screen. But if you look here, just look at the number that are due to coronary artery disease. Almost 50% of these deaths at post-mortem are due to coronary artery disease in our population aged less than 35, for which we are unable to screen or would not be picked up on a physical examination, history and ECG. If you wanted to take a strategy of just screening, let's say screen all 16-year-olds in Scotland, of which there are 66,000, if you extrapolate this data, we might expect at most one sudden, unexpected cardiac death per annum from inherited cardiac disease. We can screen. The second question was the test that we use. It is feasible to use an ECG in addition to history and examination. And this has been shown before, it's been shown in England and Wales with an abnormality probably rate of about 5%, with a serious possible condition for sudden cardiac death in about 3%. It's been shown in 35,000 school children in Chicago. It took them 3 years to do it in 24 schools. It required all the parents to volunteer. It required 3 cardiologists to attend each session to go through it. But it's possible should you wish to do it. The estimated cost in the United States to save a life would be $40,000. The problem is that assumes that we are perfect at reading ECGs. we want to go for youngsters, let's say under the age of 16, their ECGs are difficult to read, even for adult cardiologists, and even for paediatric cardiologists. They don't get it right all the time. And this is a recent study just published last year from Stanford University, which is as good as it gets in the United States. And if you look at this, only only 7% of times did they correctly identify it as being normal. So they would have identified 30% of normal people as being abnormal and subjected them to other tests. Okay, to come back to the beginning, the condition is common and disabling. I would say it isn't. It doesn't. The screen for inherited cardiac disease does not meet that condition. The screening test is reliable, valid, repeatable, acceptable, and easy to perform in a sensitive city at low cost. Perhaps. The treatment should be effective and available, and there is an immediate policy on who to treat. We don't know how to stop people dying once we identify them. We can make a stab at it. We can treat lots of them, but to identify the individual, that specific individual, who may die from an electrical abnormality, who would then require an implantable defibrillator, we would struggle to identify that particular individual. Thank you very much. I apologise for working with a Mac. I'm going to stay with Windows forevermore. Thank you.
I'm Murday, and I'd just like to say thank you as well to the organisers for asking me to speak at this meeting. I'm a clinical geneticist, and therefore screening is really my raison d'etre. But it falls upon me to perhaps say a little bit about genetic testing. And whilst we've heard quite a lot about the advantages of genetic testing, I would like perhaps just to point out some of the difficulties that we have. Now, if I can organise my talk. Okay. Now, is it just push that button there? I'll just touch it. Okay. Now, we've heard how at post-mortem a genetic diagnosis may be made as a result of finding abnormal pathology. And for us in genetics, obviously these identifiable causes are just as important as those individuals who have a sudden unexplained death. Their families need to have testing, follow-up and screening in just the same way as those that we've been hearing more about. However, genetic testing in these particular conditions is much more straightforward. You know that there is a genetic condition very often in the family, and so the information that you give families is much firmer, and you're able to give far better information about what the possibilities are in the future, the prognosis for those that have inherited the condition. Not so, unfortunately, for the sudden unexplained deaths. Now, a genetic alteration is not always identified in families who have familial arrhythmias, even if there is a strong family history, which tells us that we don't identify a genetic change in every family. And because of that, if we do testing in someone, do a molecular autopsy in someone who's had a sudden death, the finding of nothing does not mean the condition is not genetic and that one of those conditions doesn't exist. So one of the really important things is to get across to the family that the finding of nothing on the molecular test does not mean that there isn't a genetic condition present. And as we've already heard, we can even screen the close relatives and find nothing, and again, that's still not a guarantee that there isn't still some risk to the relatives. The other problem is that the results that we get from these testings may not be clear-cut. Sometimes we find an alteration in the gene and we can be certain that that disrupts the gene that the protein will either not be produced or that a very abnormal protein will be being produced, and therefore the result of the genetic test is definitive. But very often we find variants in these genes and we don't know what they mean. Sometimes we have a little evidence they may disrupt the protein, sometimes we have no evidence at all. So finding these results can be very confusing, both for doctors and for families, and the explaining of these sorts of findings to families is very important. The other thing was touched upon earlier: the more genes we test in an individual, the more likely we are to find these variants. These variants are normal variants, they're variants that we all have. And the more genes you look at in an individual, the more likely you are to find these innocent bystanders. And when you find one, it makes it extraordinarily difficult to interpret exactly what's going on. Now, in Scotland, we're very lucky because genetic testing is available for families where a sudden death has occurred. But for this to happen, as you've heard over and over again today, a sample must be available from an index case. Occasionally, we can test an affected relative who's been identified on clinical screening. But if we don't have a sample from someone in the family who is affected, then it does make the thing extremely difficult, because if people have subtle abnormalities on an ECG or something like that, are they really affected? Are they really an affected member of the family? Can we really do a genetic test in that individual, and then if we find nothing, say there's nothing to be found? There are, of course, enormous advantages, and I don't want to minimise these for families. If we do identify a definite genetic alteration, then of course it confirms the diagnosis in that family. It allows testing to identify those who can be offered screening in the family long term. And perhaps even more importantly, for those who do not inherit the gene, they can be reassured about themselves, and they can be reassured about all their descendants. As our knowledge of genetic disease increases, this knowledge is allowing us to alter management for different sorts of families. And we've had this for quite a long time in non-QT, because we know that for various drugs, that if you avoid them, then of course you can minimise the risks to yourself. So already we have some disorders which, if we find them, we know that we can modify the risks within families. In addition, there are some types of genetic disorders, such as cardiomyopathy, where different types of cardiomyopathy may have different risks attached to them. Example might be, for instance, in dilated cardiomyopathy, which is due to a lamin A mutation, then we know they're at higher risk of having a sudden death and an arrhythmia, so you might be more willing to put in an ICD into somebody who has dilated cardiomyopathy as a result of a mutation in this particular gene. But beware. There are disadvantages as well. One of the first things, and probably one of the most important things for us as geneticists, is that we are unable to know what will happen to those in the family who have and have been shown to inherit the gene that their relative who sadly died has. This inability to know what the risks are makes it extremely difficult for counselling. People who have had an alteration found in their gene are often keen for their children to have testing. But this in itself raises a whole spectre of problems. First of all, some individuals don't want to know whether they have a gene that may cause disease. If you test a child, you take away that child's right to make that decision as an informed adult as to whether they want to know if they have the gene or not. Also, for diseases which largely affect adults, and obviously some of these disorders affect children as well, but in many of these conditions it's mainly in adulthood you get problems. If you test a child, is that child's activity going to be changed? Is the way you handle that child going to be different from what it would be had you not have known that they carried this gene? In addition, when very tragically an individual dies in the family and a gene is discovered, and the parents who to date have been symptomless have a genetic test and one of them is found to have a gene, very often this will result in terrible guilt feelings for that individual. We all feel guilty about what happens to our children, whether they have something that's genetic or not. But this is something that has happened without their prior knowledge. They've handed on something to their child which has not only caused a personal tragedy to them, but a personal tragedy to many other members of the family and the individual themselves. In addition, if we cannot predict what will happen to these individuals who have a gene, when we speak to them about the possible risks, will this mean that they give up activities or careers with very little evidence that anything would have happened to them in the future? Many individuals who have a faulty gene will never suffer any effect of that gene throughout their lifetime. For those individuals themselves who have the gene, what about the anxiety of that they have to live with from day to day? Someone in their family has already died suddenly, will they be the next one? In addition, as I mentioned earlier, what we discuss initially with the family as being a normal variation may later turn out to be a gene or vice versa. We may tell somebody they have a gene which we believe to be pathological, and yet later on other families come forward and we find the gene in the normal population, and we realise that the information that we've given them, although given with the best intent initially, is in fact incorrect. As Iain mentioned, there may be no preventative treatment for those who are unaffected clinically, that have the gene. So they have to wait and wait. In addition, individuals who carry these genes worry about their children enormously, even those children who are yet to be conceived. We've heard about long QT and how there's a great variation within the population and how it can be modified by environmental factors. And this makes the interpretation of these genetic tests very difficult. If you look at the QT interval, this is normally distributed. And you can see here it goes right down to 300 and goes well over 450. If you compare, and I hope this is going to work, those individuals in the normal population with those who have the long QT syndrome, you can see there's enormous overlap between the two. So if you do an ECG on an individual in the general population and it's in this range, these people could either have long QT or they may belong to the normal distribution. And the same is obviously the same the other way around. That's extremely important when you come to think about population screening particularly. This is just a completely hypothetical situation, but it's, when people are talking about population screening, what you have to remember is that these disorders are very rare. So if you have a long QT randomly discovered and you're asymptomatic, the a priori chance that you belong to the general population is far higher than you're likely to have long QT syndrome. So here we are, we're going to do our screening at school leaving. Anne is leaving school, she's looking forward to her career in sport, she's never had a serious medical problem, she's never had a collapse in her life. You do her ECG and her QT interval corrected is 460, which we would normally consider to be in the abnormal range, although we know there are people in the normal population who have a QT interval such as that. So we do a genetic test. That will prove it one way or the other. Unfortunately, it may not. We get one of these variants, an alteration in the long QT1 gene. It's never been reported before in people with the disorder. It's never been seen in the general population before. And you run various software packages and it says, well, possibly it disrupts the protein. So is this person to give up their career, to change their lifestyle, and all the effects that may have on them in the future? Well, this is some very interesting data which I hope will show you that even at a QT interval of 480, which is well into the abnormal range, in somebody who is female and asymptomatic, only 4% of those individuals will actually have long QT syndrome. Now I want you to compare that to the asymptomatic child in a long QT family, where the QT interval here is only 440, but in that context where the individual is at a 50% risk of having the disease, then there is a very high chance, 50% chance in fact, that that person will actually have a long QT syndrome. So these clinical tests that are done in the general population do not have the same sensitivity and specificity as they do when we're screening families. And that is why we favour cascade screening, because the interpretation of testing in these families is clearer, and we know that if you have a family history, that there is an increased risk to those individuals within the family of having an event themselves. So you're identifying automatically a higher risk population, a different population. So choice is important as well, and in genetics it's paramount. In genetics we tend to discuss these issues with families, and we always leave it up to the family themselves to make the decision about what they want to do. For us to do anything, however, frozen tissue must be available. And when we see these families, it's usually at a very raw time in their life. And in order for these families to benefit from what's going to happen, and for them to be able to make a reasonable decision about whether they wish to have testing or not, it does require to have very experienced counselling services. I believe that early intervention in the families is paramount because these people need a pathway through this process. One of the difficulties is they get given the pieces of information and then left for weeks, and what seems like a short time to us is actually a very long time for them. Also, we get a lot of referrals from more distant relatives, and really what we need to be dealing with is the first-degree relatives. We need to address predictable issues with them, such as guilt and worry, before any testing is initiated. And they need to know all the advantages and disadvantages before a test is done. One of the most important things, I think, is that none of this must be done in a rush. And of course, lastly, and most depressingly, the service needs to be adequate resourced.
Thank you very much to the two last speakers for illuminating us on these issues. I'm not sure if it's brought us any nearer to